health change and what we should truly aspire to. And then in 2022, just to talk about a New England Journal of Medicine Catalyst report, a high percentage of clinicians and administrators in hospitals and healthcare settings say that patient health has been improved by SDOH, social determinant initiatives in their organizations. So on that note, Bonnie's going to tell us how that can happen. And we need these investments on how we can better make them. So thank you.
Hi, everyone. Wonderful to be here this afternoon. Thank you, Robin. Oh, we'll need that. All right. Thank you, Robin, for talking us through the imperative and our framework for the types of activities we're talking about trying to get investment in. I'd like to first start by just naming what are some of the typical funding sources for some of these diverse social care activities. We have grant funding, healthcare funding, governmental funding. So just to start at the top, governmental funding, this could include like SNAP funding, for instance, home delivered meals through the Older Americans Act. We have state funded initiatives like in Illinois' Choices for Care program that embeds care coordinators in hospitals to support folks as they go home from the hospital. Public health initiatives, we've seen a lot of public health dollars in the last few years be leveraged through a really, in an intentional way to not just do contact tracing, et cetera, but to help address social needs so people could isolate, et cetera, if they had COVID or were exposed. There's been federal and state funded demonstration projects. I'll talk about a few of the things on the Medicare and Medicaid innovation side, but we've had demonstration projects, like one we were involved in was through HUD, for instance, Housing and Urban Development, looking at supporting resource coordinators based in housing sites. So kind of these, a number of different ways that the government is funding existing kind of social care resources and also the workforce providing some of these services. Also, of course, grant funding. This is one of the major sources. That's why I came up on the screen first, a mix of philanthropic funds, individual donors, and then some of the governmental funds are grants technically instead of contracts. And then there's the whole realm of healthcare financing, where we hear often, we saw in the chart that Robin showed, that nearly a fifth of our country's GDP is spent on healthcare dollars. Most of this is, it's through healthcare insurers. There's mechanisms I'll talk about a little bit, kind of the historic model of billing fee for service, but increasingly moving towards other kind of reimbursement models. And then ways of thinking about leveraging hospital operational dollars, for instance, to maybe try to make an impact at a broader level beyond the individual patient intervention, and a lot of alignment opportunities there. However, we know that that in the current state, that good intentions by clinicians, systems, all of us in our daily work are really stymied by payment restrictions and the outright lack of direct payment for social interventions. So to make this work in the real world, most of us are pulling together support from various types of sources to support actual social care activities. This, of course, makes it so that we need to be coordinating funds with different timelines, different kind of reliability in terms of knowing upfront how much you might be getting versus waiting for certain numbers of referrals to come through. It makes it so that we need to track sources with kind of different deliverables and different timelines. So there's challenges there, but of course we all know how important it is to kind of diversify our investment portfolios. So for that same reason, this kind of braiding and blending funding approaches are often used. Folks might have heard those terms before. I'm just going to put two images up just to communicate what we generally mean by braiding and blending, but it's just two different ideas of taking multiple funding sources coming in, and with braiding, the idea is that you're still tracking, okay, I have this revenue source A that's supporting this concrete resource for this patient population, revenue source B supporting this concrete resource that allows us to do this advocacy work, but continuing to track those the revenue and the outcomes at the individual level. So that's kind of this concept of braiding, and then blending is this concept of kind of pooling the funds and pooling the outcomes that you're collectively working towards, and having all of the original funders on board with that, and all kind of transparent arrangements. So I just wanted to mention that a lot of our organizations on the ground are actively doing this to make our programs run. The National Academies report that Robin was talking through the social care activity framework from, they did recommend, based on all the research, the live testimony and input from the field, that CMS, the Centers for Medicare and Medicaid Services, and other groups really do pay more attention to financing of health and social care integration. I'm going to walk through some of their recommendations in the upcoming slides. But before doing that, I definitely want to say that we recognize that a lot of, in order to achieve health equity and to address a lot of the systemic and infrastructure gaps, and also core other challenges like systemic discrimination, we know that there's a lot more than just the kind of investments that we're talking about today. Today, we're kind of on this focus of health and social care integration, while we also are kind of keeping our feet to the fire on some of the broader systems change pieces, like transportation, affordable housing development in the first place, environmental justice initiatives, and making sure everyone can have access to the internet. Okay, so the National Academies report outlined kind of 5 focus areas. I'm going to talk through these one at a time. So the first one, update legal definitions of healthcare. And what they really are talking about here is looking within our current, they're focusing on Medicare and Medicaid, but within the current kind of reimbursement system, how do we look more broadly at what healthcare is to kind of expand that infrastructure? Dr. LaShawn McIver, the director of CMS's Office of Minority Health, said in a piece last fall, as the nation's largest health insurer, CMS has a critical role to play in driving the next decade of health equity for people who are underserved. Our unwavering commitment to advancing health equity will help foster a healthcare system that benefits all for generations to come. And I think this leadership from CMS on recognizing how they can be looking at CMS policy to better support Medicare and Medicaid beneficiaries today, that's really important. And what I like about this quote is it also calls out the systems change role that CMS plays, and commercial payers, other groups are looking at CMS for leadership. So what I'm about to talk through about some Medicare developments as one example is really exciting, not just because it'll open doors for current Medicare beneficiaries, but hopefully contribute to some of the broader healthcare culture change, and again, expanding this view of how we all think of healthcare. So just a quick to kind of share the grounding definition. Folks have probably heard of fee-for-service reimbursement, reimbursement structures. There's a lot more nuance we could go in here, and people in the audience could probably help me with that nuance. But at a high level, I just want to share that we typically in healthcare have reimbursed on this volume-based basis, or fee-for-service. So you provide service A, you bill for it, the organization gets reimbursed, you provide service B, et cetera. So FFS, you'll see the acronym on some of my slides. So in order to get to a world where we can have some of our social care activities potentially be reimbursed through the fee-for-service mechanisms, we need codes or other ways to capture and describe what we do in a concrete way, and we need the insurance or the folks that might be paying for that to approve that. So those are kind of 2 of the important movements. There's various types of billing codes, approval processes. I'll be focusing mostly on what are called CPT codes, current procedural terminology codes, that the AMA helps oversee in collaboration with CMS. So a couple slides on some Medicare developments. So first off, Medicare statute limits Medicare coverage to only being on items and services that are reasonable and necessary for the diagnosis or treatment of an illness or injury, which makes it hard, if you're talking about diagnosis and treatment, to kind of talk about the value of social care activities when there's certainly value on treatment. There's ways that social care helps with diagnosis, but we also know that probably the biggest impact of social care is on prevention in the first place. And we've seen through some kind of basically recent regulatory actions over the last couple of years under President Biden's leadership, kind of this more comprehensive view of looking at what are, given the statutory language, potential opportunities to have Medicare be a little bit more responsive. Supported by the Affordable Care Act and some other legislation, we've seen a lot of development on how Medicare fee-for-service has started to support the kinds of care that we're talking about today, from annual wellness visits to more monthly, like billable codes that actually reimburse primary care based and other teams to provide care coordination and behavioral health integration. Some of those billing codes that folks might be familiar with are like chronic care management is the most common code set family that is really relevant here. Behavioral health integration, which has a number of different billing codes that are part of it, and could dig into all of these a little more in the conversation or in Q&A, excuse me, as folks are interested. But one really kind of important thing just to highlight as the big picture here, in order to try to reinforce continuity of care and build on the primary care, relationship, the way that these are structured is that these codes are all billable by the physician or other qualified health provider, which typically is a physician's assistant, nurse practitioner, and there can be services provided as part of the healthcare team, which is really helpful. CMS, like for instance, chronic care management, which I believe was first introduced in 2014, around then. From the beginning, CMS recognized, going back to that 2009 report that Robin showed, the value of interprofessional team members. And so even though these codes are, the physicians and others are the kind of qualified health providers, from the beginning, they've recognized that other team members would likely be providing a lot of those chronic care management services, which is exciting to have that recognition. Yet it's been very, very difficult operationally to grow the use of those codes in the field. I personally at Rush worked on it for several years, trying to make it happen at Rush. We have folks that are still working on it. There's challenges, and I think there's a lot of opportunities, but things that we are very excited about, I think, are that CMS is recognizing that there's a good foundation with the chronic care management codes, et cetera, to build on to support this team-based work. And as CMS in that quote earlier emphasized, they're really looking at how do we make Medicare and Medicaid work better for everyone. And as part of that, they recognized an opportunity to have more Medicare recognition of services, some of these wraparound services. So actually just in this year's proposed what's called the physician fee schedule. So in July, CMS releases their proposed Medicare policy for the next calendar year. So in what we heard this July and is now being finalized, and we'll learn for sure in November, is that CMS is proposing to have a number of really, what I'm very excited about, positive changes on Medicare Part B side. So some of those are listed here. For the first time, they are going to recognize and reimburse for social determinants of health screening completed on the Part B side, just like they have in the past for depression screening, as another example. They are going to recognize and reimburse for community health integration services, which are, again, billed through the primary care provider typically, but explicitly recognize the value of having community health workers, patient care navigators. We advocated for them to recognize social work, non-clinical social workers in that camp as well, folks who are in care teams providing community health integration services across the country. So CMS proposed that, and they're, again, looking at how they're going to finalize that rule. Similarly, they also proposed principal illness navigation services, which kind of complement the community health integration codes and would support, if it's mostly focused if someone has one focus of care, one illness as a focus of care. So cancer care is one common setting. That was, I'm on the National Navigation Roundtable through the American Cancer Society. And everyone was really, really excited about what this is going to mean about navigators across the country not having to only be reliant on grant funding or the Cancer Center coming up with some other way to support the team members. It's a really big deal if it does all get finalized in a similar way as to proposed. I also wanted to mention that CMS proposed recognizing a new set of codes for caregiver training services, and they recognize a number of different interprofessional providers as eligible to provide those services, such as speech therapists, occupational therapists. They neglected to list clinical social workers on that list, and we know that clinical social workers around the country, or including at the VA, are the main kind of caregiver interventionists. They certainly are at Rush, and they're key to our strategy. So we're hopeful that CMS will broaden that guidance a little bit so that those family of codes can be more fully useful to support the care teams that are happening on the ground. And the bottom bullet here is another thing that we're very, very excited about, is that for the first time, CMS is proposing to recognize clinical social workers as well as other mental health providers that are coming on board with Medicare to bill Medicare for a set of codes that are called the Health and Behavior Assessment and Intervention Codes. HBAI is an acronym that you might hear for those. HBAI codes reimburse for assessment and intervention of factors that affect how people engage in their healthcare and other factors that affect people's health. So there's a lot that social workers do that are perfect fits for HBAI codes. Historically, psychologists were the only folks that could bill for them. And social workers, there's some kind of complex policy barriers that have kept it hard to have made it so that CMS hasn't been able to recognize social workers in this way yet. We're very excited to see that proposed for this year. And as I'll kind of close with today and share more details on, we're also working on a legislative route to fix one of the core policy barriers, because while it's very exciting that President Biden's administration is recognizing this, we also know that unless it's kind of codified in statute, it could shift in the future. Okay, so I'm going to shift to talk for a couple minutes about Medicaid, which of course is also very important on the social care side of things when we think about folks across the country who are lower income, that Medicaid is their main insurance source. States have a lot of different options when paying for social care. There's a lot of details on this slide. I'm not going to go into that many details on this, but hopefully they're a helpful reference in the future. Just want to mention that states go through regular kind of overall state plan negotiation and amendment processes with CMS as part of their kind of proposal to serve everyone in our state. Here's our plan. They also, as part of that, can propose to participate in different kind of unique or special opportunities, such as a health home initiative that was made available to states. They can apply for specific waivers to certain sections of their requirements. And so it's through some of those pathways that states are able to look at potential flexibilities. Folks might be familiar with Medicaid, that Medicaid covers long-term care. Medicare does not, but Medicaid does cover long-term care. And at this point, most, if not all, states have gone through what's called the 1915B waiver process to say, hey, we're glad Medicaid covers long-term care if people need a skilled nursing stay, for instance, but it would be great if we could leverage those same dollars and pay for people to stay in the community instead. And so CMS can then say yes and grant that waiver. So across the country, there are Medicaid home and community-based services available, typically leveraging the 1915B waiver process. I wanted to mention that because a lot of that stuff is what we think of when we think of social care. Transportation, folks coming into the home to help you with your laundry, supported employment supports, those kinds of things. Another things we're seeing around the country moves towards Medicaid managed care. Again, I think it's over 40 states at this point have managed care arrangements. In Illinois, the majority, I can't remember the numbers offhand, but certainly the majority of folks in our state are being moved essentially over to managed care arrangements. Um, there's a lot of oversight, et cetera, that is important for us to have in those arrangements. And it also opens the door for some opportunities with what's called in lieu of services, which is a similar kind of idea of saying, hey, instead of paying for X cost that is in kind of Medicaid requirements to cover, we would like to propose to cover this in like this way instead, and it's going to cost about the same amount of money. So the in lieu of services mechanism is kind of the state's official way to say, here's what we would like to do instead of this, and here's why we think this will be a good substitution. Just last year, CMS released guidance saying that states could use this in lieu of services mechanism to not just be an immediate substitute, but to try to prevent. So there's a lot of examples we could think of, but to say, okay, we want to work on helping address mold infestation. So we're going to use a pathway for in lieu of services to prevent some future procedure that might be related to asthma. I'm not familiar enough with the healthcare needs. But instead of that procedure, we're going to propose to CMS to have an in lieu of approach and be able to actually pay for someone to come remove mold. So that's one mechanism through the Medicaid waivers, or through the managed care, excuse me. And then last, the 1115 waivers, a broader waiver that's very relevant that a lot of states, including Illinois, have leveraged. And CMS has recently said that they're really looking there at housing, nutrition, and case management for health-related social needs as their main priorities. Okay, so to keep moving through a little bit here, I'm looking at time and aware, I want to get through a few more pieces. Medicaid really just is, for the broader reasons of how CMS is a broader leader in this work, Medicaid is a really important kind of data source and kind of compilation of demonstrations to look at, because there really are 50 plus with DC and Puerto Rico systems that are all trying things in similarly but slightly different ways. We also see a lot of leadership at the state level, like on the community health worker side, for instance. We see 29 states are currently have pathway to have some reimbursement for community health worker services, the mix of through managed care organizations, some it's actually built into the state plan amendment. Illinois, if folks are tracking what we're working on here at all, or we're in process of this, of first getting a formalized certification and then with the plan to build it into our state plan. So a lot of development and momentum kind of there at driven by Medicaid. And also we're seeing, as I showed a couple of slides earlier on Medicare, learning from the state's innovation in Medicaid, leveraging CHWs, and how Medicare is looking at that. So it's just a lot of momentum. I'm going to move us through and now touch on the second overall area of recommendation from the National Academies was to reform healthcare payment overall, and this is looking at alternative payment models. So we know, of course, that social care aligns with value-based care incentives, promoting health overall, preventing exacerbation of conditions that might have been made not quite as worse if folks had what they needed in the first place. As some examples, social care also helps folks engage in care. Robin talked about no-shows and appointment attendance as one example. We've data on reducing ED visits and preventing likelihood of folks coming back to the emergency or to the hospital itself. We are seeing investments in value from kind of value-based care arrangements in social care in limited areas. We're seeing pilots to send food home to people for 6 months if they have hypertension, and like that as one concrete example. We're seeing United Health Group invest in affordable housing more at the community level. Within Medicare Advantage, there's a lot of opportunities to have the Medicare Advantage plans be able to make available some kind of very defined concrete benefits. However, I think across the board, at least from what I've seen, it's been hard to things haven't persisted in a way and become available to broader populations outside of kind of specific chronic conditions, et cetera. And it's really hard to pin down the exact outcome of any of our one activities, especially when we're trying to be person-centered, and especially when our activities have this blend of micro and macro, like Robin talked about. Yet we're working in this world, and I think there's a lot of benefit and opportunity where CMS is pushing us to move more and more towards payment mechanisms where there is a little bit of risk or potential penalty or potential upside based on how we perform either on quality measures or on cost. This graph is pulling out from kind of CMS's latest description of what their target is, that in 2021, 44% of Medicare beneficiaries were covered by getting care at a primary care provider, or were on a plan where they where the providers had some kind of accountable care arrangement. CMS wants that to go from 44% to 100% by 2030. So that's a big shift. That's at the beneficiary level, but at the organization and provider level, that means they want every single provider to be kind of in these arrangements where there's some adjustment on what the provider is getting, essentially based on outcomes and quality measures. A lot more discussion that we could have there. The third area of recommendation is boosting accountability. So looking at classification procedure codes to describe services. We're seeing a lot of increasing attention to incentives and recommendations for healthcare to screen for social needs. CMS is requiring it now on the hospital side, soon to come on the outpatient side. NCQA, which does HEDIS measures, if folks are familiar with those measure sets that describe health plan quality and outcomes. NCQA has a new HEDIS measure. I'm sorry about the formatting transfer issues. Joint Commission is encouraging screening for representative sample of folks. So a lot of attention to an encouragement to healthcare to begin screening for needs. And attention to how can we capture that data in a consistent enough way so that we can communicate across systems and communicate in a way that we might, and research and communicate in a way that we might do so around health, physical health conditions. So that's where this world of Z codes comes in. Folks might have heard about Z codes. They're a family of diagnostic codes on the ICD-10 diagnostic code side. And they just describe factors that influence health status and that influence contact with health services. So some examples of Z codes are, like, one of the larger categories is problems related to employment and unemployment. There's a lot of specific ones under those, but you can imagine that as we collectively work on getting social care more integrated in healthcare, that kind of codifying how everyone is capturing needs, et cetera, would be helpful for alignment and research again. The Gravity Project is one nationwide initiative that was funded initially by the Robert Wood Johnson Foundation and with the Social Interventions Research and Evaluation Network out at UCSF that's leading a lot of this work. And I recommend folks check out their website if you are interested in learning more. The fourth kind of piece that I'll just briefly call out is that the National Academy's report named the importance of looking specifically at folks who are dually eligible for Medicare and Medicaid as we think about financing. There's a lot of development happening. There have been a lot of initiatives through the Innovation Center, a lot of building on Medicaid managed care that we already talked about to figure out how to best meet needs of folks who are Medicaid and Medicaid beneficiaries. One piece I want to call it specifically is PACE, the Program for All-Inclusive Care of the Elderly, which is generally around the country is supporting folks who are dually eligible, but providing the care all, for the most part, in one physical center or as one core coordinated team. And this care includes a lot of social care, including transportation, meals, adult day services, nutritional counseling, social support groups. So PACE is a wonderful model to learn more about. And in Illinois, we are just beginning to have PACE sites roll out in real action here, which is wonderful. Okay, last area of recommendation is to increase capacity, the administrative capacity of social service providers so that we can enable workflow or bidirectional workflow and communication across sectors. We know that community-based organizations are trusted leaders in many cases, partnering with communities to understand their needs, address their needs. Community-based organizations are funded through networks to provide these services, so it doesn't make sense for healthcare to come in and just build on its own. We know that demand for community-based organization services is increasing as healthcare is increasing to identify needs, and unfortunately, as the needs persist with the pandemic, et cetera. And we know that community-based organizations haven't traditionally been funded to have the infrastructure and kind of technological resources needed to keep up with all of these referrals, but also to, say, meet our the cybersecurity requirements that it takes to contract with a health system and to be considered what's called a covered entity, just as another example. There's challenges CBOs have with recruiting and retaining staff because of some of their funding sources. So lots of challenges, but also opportunities. We're seeing social health assistance referral platforms, Unite Us, Now POW, that developed out of U Chicago, Find Help. They're like these online platforms that are sort of like Yelp in that they curate information about resource providers, but also have the ability to provide some reviews and direct referrals, which can be really helpful and can also be really challenging for the organizations that might be asked to be participating in a couple of these different platforms and not getting any additional funding to be able to do that. Nationally, luckily, we have the Partnership to Align Social Care that is working on some of these issues, that's bringing together leaders from across sectors, including payers and government, and with strong leadership from the community-based organization side to try to better align systems here. One structure that they're advancing is called community care hubs. And what community care hubs do is essentially make it easier for a healthcare entity, such as if I was at Rush making this decision, to contract with community groups and to have a facilitated process so that it's kind of one contract with an umbrella agency that organizes this whole hub of, say, 30 providers. And so it's a kind of an organized, streamlined process so that I, as on the healthcare side, don't have to be creating 30 individual contracts and figuring out 30 different workflows for X and Y needs. So that's kind of the idea. And nationwide, we're seeing community care hubs really making a difference, not just at kind of patient level, but also at the geographic level when they are able to bring partners together. I will mention that the Administration on Community Living, ACL, which is under Health and Human Services, just funded a big center of excellence focused exclusively on this that's run by a nationwide group called US Aging. Okay, I'm gonna just spend a few minutes talking about our social work campaign and then we'll, yeah, as Jean opened at the very beginning, talking about our Coalition for Social Work and Health, which has been a project that we've collaborated with Chaz and U Chicago, but a number of social work leaders around the country on for several years. So why focus on social work? We know that there are many important disciplines to have at the table, and we are focusing on social work because we know that they're getting left out of the conversation, unfortunately, despite an ability to really continue making a big impact on health and health equity. We are in the midst right now of a national campaign to work on telling this story and trying to get more people on board. The language that you see on the slide right here is some language that many of us social workers and non-social workers alike have honed to try to have simple go-to phrases to say, social workers make an impact by skillfully supporting people today while working to build stronger systems of tomorrow. Social workers promote health, social workers enhance hope, social workers improve healthcare outcomes. We have a lot more talking points along with that, but that's just kind of to share a little bit of a taste of what we're trying to do to help broaden recognition of why social workers should be at the table. We also, I alluded earlier to the definitional, kind of one of the policy challenges that's we're trying to address. Social work services are defined in Social Security Act specifically as around mental health services. This was in order for social workers to get recognized as mental health providers, kind of how We had to get in, which was helpful to now have social work be one of the largest mental health professions. And now it's time to think about how to broaden that definition so it's not restrictive, because now that definition is used by groups, or can be used by groups, to say, such as our compliance department, say, no, clearly social work is called out as a mental health profession, so why should social work be able to provide chronic care management services as part of the healthcare team? That's like a real world example of something we had to troubleshoot at Rush and advocate around. So because of this restrictive definition that limits organizations' abilities to have this workforce, have a revenue source for this workforce, and ultimately it limits access to Medicare beneficiaries for services such as health behavior assessment intervention services, advanced care planning, other services that Medicare might recognize down the road. To help address a lot of these issues and kind of organize different partners across the field, we have created and continue to lead our Coalition for Social Work and Health. We already called out the historic and leadership role that Chaz at UChicago has played, National Association of Social Workers, CSWE, other players actively working together. We're in the midst of a campaign, as I mentioned, to develop communications materials, but also to train folks, put educational materials out there, and advance policy advocacy, especially legislation we were very excited to have introduced recently by Congressman Danny Davis and Representative Jen Kagan, that would address this definitional issue fundamentally, the Integrating Social Workers Across Healthcare Settings Act. We had a wonderful press conference, and we're happy to be on the cover of our Garfield and Lawndale newspaper that some of our community members on the west side get, and are very appreciative of Representative Davis's office support in particular on that. So here we invite you all to help us with this campaign, but also more broadly, shine a light on why social work and healthcare, why social care in general. We've got lots of resources. You all will receive these slides. If you're interested in getting on board with the legislation itself, we have toolkits, social media toolkits, et cetera, and an email here if you'd like your organization to endorse. We'd love to partner with folks in the future as well. And I want to just name some broader opportunities for impact. CMS, I'm showing here on the screen, has what I find to be a nice framework for health equity priorities. And each of these, I think I went through the exercise to think, how could I apply this priority kind of to my own work? And I encourage all of us to kind of think about them from that lens as a call to action for yourself, wherever you are in your own studies or your own work. And invite you to advocate for policies that invest in the things we just made the case for needing, the workforce, programs, and the community level investments, and to do it in a way where you are engaging in research about what you're doing on the ground so we can all learn what's working and how to make it easier, but also engage in practice that's based on research that's been done to date. And do those things in a way that can, again, help us fuel for future policy change and education for future care providers. This is a nice quote from Javier Becerra, our current secretary of HHS, that I'll kind of read and close on as we turn to Q&A. We'll keep making equity and justice our North Star because we know healthcare is about more than just mending bones or dispensing pills. It's about giving people access to peace of mind, to economic security, and to a brighter future. That should belong to everyone, no matter where you come from, what your color, what language you speak. We think all Americans have that opportunity. So with that, we'd love to open up for any reactions, comments, and questions.
The policy that CMS is having for 2024 to like have the new codes. I'm curious if it is just going to be sort of like a reorganization of the funds they already have, or if there's also going to be like an increase, the government is going to increase funding to that.
That's one of the right questions to ask. I believe it's still the same size pot, so no additional infusion of funds explicitly to cover those services.
Yes, please. Go ahead.
Robin, this is so interesting and such amazing work. It's really, really fun to hear the whole report and everything you're still doing. So thank you for that. I was curious if you recently, Sherry Gleed and Tom Diano had a piece in JAMA. And Robin, I see you shaking your head, so maybe you saw it. It was really about, not about social work in particular, but about, should we really be integrating social care into healthcare if it's going to be the healthcare system that's really running the show? And I know you guys worry about that a lot. And so I just was curious, when I look at some of the systemic reforms, they're really important for getting things covered, but they don't really get at this problem of who has control, and kind of like social work is sort of subsumed under other people making decisions. So I just wondered if you have any thoughts
It was
about
such a
that.
provocative article. Of course, you would think of that, Colleen. But I think it's going to be it's a dilemma if we're going to medicalize social services. Yet, how is it going to get paid for in this super gorilla system of the 800-pound gorilla of CMS, dwarfing the little that goes into the human side of health and human services? So it's a really tough one. Do you have anything to say about that?
Would love to further discuss. I think it feels like, to me, I think healthcare it's really important that healthcare is doing their part. And so it's, how do we not make sure that that overshadows? I brought up like the buy versus build, to not get in the road of the short term, we want to build versus buying and investing in other leaders and working towards fundamentally shifting power dynamics.
Is this on? Can't hear anything. Oh, yeah, there it is. Adam Scheffler, a graduate of SSA/Crown. Tom Diano was my advisor, so shout out to him. Very, very great presentations. I wonder though if we're still tinkering with a system that's fundamentally flawed. I mean,
Of course.
What we really need is restructuring of the system according to first principles, and we're never going to get that. And the other thing is to foreshadow Professor Grogan's presentation. We've got this corporatization, financialization of the services that aren't controlled by CMS, and they're rapidly gaining control over public services as well. So, we're all paying the piper here.
Absolutely. And I hope it didn't feel like our suggestions were Band-Aid approaches. I think we've struggled with what you're saying, both of you, for so long that we just had to dig into something, knowing, if we only had global payment, if we could only show the impact of a social service agency on the overall health outcomes, maybe more money would go to all of that. But totally agree, can't disagree. We've just tried to, I hope we haven't put our head in the sand, but I think
I think it's good to name. Certainly doing payer-based initiatives where you have to do something a little bit different because of someone's health insurer is it's just not the ideal way to work, nor can it be efficient, I wouldn't think. It's been really exciting seeing public health dollars in recent years. Like for our team, that's meant our social workers and community health workers could serve anyone, patient at Rush or not, family member, oh, my neighbor had this question, can you serve them? Yes, because our goal is to improve the public's health. So definitely recognize that broader need.
Oh, no, no, it's my own, it keeps me up at night.
Yeah, no, it's just, it is a puzzle, which, I mean, I've been grappling with it too, as have, so many people, but I wonder when you're thinking about legislation and, like the pilot program in North Carolina, the 1115 waiver. To me, what's quite interesting about that model is for those of you who don't know about it, the managed care company contracts out with a coalition of social service, like the coalition gets the money and then they distribute to the social care providers.
Right.
And so it just seems really, but I don't think they've gotten a really good contract, right? So that they are able to have leverage.
Yes, this
with the
happens
managed
all
care
the time, right?
organizations. Yeah,
right.
and so it seems like we need to be thinking politically
Right.
about creating coalitions that then maybe have some power in this system.
Yeah.
I don't
And then the
know.
managed care can say they're partnering, they check their box, yet they're not sending any business their way. That's what happens a lot.
But states can build that in to managed care requirements, to contract with certain other funded. So,
Yeah. No, I think there's
That's the
possibilities,
political-
but it's
That's
kind
the
Yeah,
lever,
but
right?
it's-
State
about
level.
what's the lever.
Mhm.
State level. Uh-oh.
Former director, Eddie Lawler, happy to have you back in the audience.
So as you know, social determinants is a very broad basket. I have a friend who believes that this social care ought to be framed as precision social determinants, sort of analogous to precision medicine. Back to your, do we join or fight the medical model? I'd be interested if you sort of accept that premise. And do you see progress in this? It seemed to me some of the Medicare changes have that character, actually. These individual assessments. And so if you could sort of just talk about that, how do we get from these broad, sweeping, rhetorical statements about social determinants to sort of interventions that are tailored and targeted and you can actually pay for?
What's happening? I mean, that's what's amazing, is that it's happening. I mean, the fact that CMS has some of that in there in such a big way, and we've all been allowed to comment on it. I never thought this day would happen. So I absolutely agree with I think we have the same friend who talks about the precision medicine. And it's an interesting concept. It goes back to that person-centered quality. What would you say about that?
I think the way we do that policy-wise is by making sure we have a way to have the workforce that's skilled to do those individual level assessments, and then have a routine way to look at the data to make sure our community level investments through the variety of agencies are kind of aligned with what we're seeing at the workforce level. But certainly, like in our individual intervention research and anecdotally having our social work care managers do these conversation-led assessments that are really iterated on social work's 100 years of history doing this, but also very much organic and live in the moment based on the person and family in front of them. I guess it feels like leveraging that feels like the way to scale up rather than trying to make that an algorithm, because people are people. So it's always going to be different combinations of the tailored menu items.
I mean, just the scary piece of some of this is some of the sharps that we talked about, the now POWs or whatever. It's really nice we're curating services. It's really nice we're screening for social determinants. But if we don't have the work that goes on that we know best, that being able to engage someone around stuff that's really hard for them to engage around, that it's not going to be effective. And I think that's the piece that we need to hold on to and fight for a bit more.
That's a great question and that great response. Let's thank our.
Thank you.